And welcome back to another episode of Outside the Box. I am Andy, not your usual host, but your host for today. And we are in the Bristol location with our new Bristol provider, Jill Henritze. We are so excited to have you back and actually to do a little bit of explaining about a subject in medicine that gets brought up quite often with our patient profile, osteoporosis.
Yes.
Everybody knows a little bit about bones, about osteoporosis, but we're going to take a little bit of a deep dive. So let's get the party started. It's all about the bones.
Yeah. So the thing, you're right. We do see a lot of patients that ask us questions about osteopenia and osteoporosis and what is the difference and how do we treat them? How do we prevent them? Osteoporosis is something that affects men and women. We think about it a lot more, of course, with postmenopausal women, because it is more prevalent in that age group and population. However, it certainly can affect men just the same.
That's good to know. Yeah. Usually you really do think, okay, women first, estrogen related, postmenopausal, preventing fractures, correct?
Correct,
yes. And I wouldn't have thought about it more for men too. Yeah.
Yes, so it definitely can affect men as well. And definitely in our population, we're seeing a lot of men with low T, which is one of the reasons that you can get osteoporosis at a younger age for men. The one thing, was thinking about screening for osteoporosis, just like everything else we talk about being preventative, typically your insurance will pay for you to start.
Sorry, y'all. So, ladies and gentlemen, my dog is also here, Todd. He's just making a little bit of a noise right now.
He is passionate about osteoporosis.
He cannot wait to, you brought up bones.
Yeah,
and I think that's what he was thinking too. So thank you. Todd's making a little bit of an entrance later on there. But you're saying screening. So screening for men are getting low T and subsequent osteoporosis as well. So screening for them is also important.
It is, yes. And typically screening for men does start, unless there's a reason to do it sooner, because we know that they have hypogonadism at an earlier age, or I've had actually some patients over the years that had testicular cancer, of course, which has led to, again, kind of a surgical throw into hypogonadism. And we have to start treating them sooner. And of course, treating with testosterone replacement therapy is going to help prevent that, just like treating with hormone replacement therapy for women will help to slow the loss of bone and to help prevent osteoporosis. But sometimes there are other factors that play a role, and that may not be enough for treatment, although it's helping. But screening can start for women really whenever there is multiple risk factors, or if you have an insufficiency fracture, which is a fracture sustained from standing height. So when you fall from standing height, you should not break a bone, right? So sometimes we think that's normal. Well, you get older, you break a bone, that's normal. Well, that's really not normal. I mean, you really should not be breaking bones.
Right.
Even though you're getting older, sure, your bones are getting older too, but there's things that we can do to prevent them from getting thinner and poor quality so that you can be active and live a healthy lifestyle, hopefully with a lot less risk of fracture, or kyphosis, which is another thing we worry about. And that's what we're talking about. We think about older women that sometimes get the curvature in their back, and you don't want that. And that comes from compression in the spine, vertebral fracture, weak bones, osteoporosis. But standard screening would start around the time of menopause or 65 for women. For men at 70, unless we have reason to start sooner. And screening would be like a Dexa Scan. Yes.
So what's a Dexa Scan?
So that is a bone densitometry scan. That it's a simple test that you can do, non-painful. It's like taking an X-ray of your spine. Most of the time they would check both of your hips and your wrists, and then measure the cortex or the strength of the bone. And they'll give us a couple numbers with that, actually. They will give us a T-score, which is comparing your bone to kind of the standard, which would be for a woman like a 20-year-old female. Okay. And so if your bone were the same strength as her, then your score would be 0.
So it's like a standard deviation. It's
definitely exactly what it is. And then it's also measuring a score between you and someone of your same age. So that's called a Z-score. So you'll get both of those scores. And then a lot of times you'll also get what we call a Frac Score, which is a fracture risk assessment. And so it's looking at your bone density, but it's also looking at other risk factors, including age and possible history of tobacco use and weight, previous fracture, family history of osteoporosis, age of menses, height loss. Those type of things are risk factors. Plus, high-risk medications are another risk factor. And then the machine basically is kind of spitting out a percentage of your chance of fracture over the next 10 years, whether it be hip fracture or any any bone, really, major osteoporotic fracture.
So whenever you get these scores, so we talked about screening. Well, let's go back. We're going to come back to screening and then what do we do from there?
Okay.
And we kind of talked about risk factors that kind of give you a predilection or a little bit of a red flag to say this might be an osteoporosis patient or osteopenia. What is the technical definition? What's osteoporosis versus osteopenia for our viewers?
Yes, that's a good question. A lot of people ask that. So thinking about the T-score again, a normal score would be from 0 to minus 1.0. And in some patients, if they have very low risk factors, I might even say normal could be to minus 1.5. And you'll get a little bit of discussion on that number.
Okay.
But osteopenia would be anything from minus 1 or minus 1.5 to minus 2.5.
Okay.
And that's where your bone is starting to thin at a faster rate. We would be concerned about you developing osteoporosis. You could be at risk for fractures, and we'd want to start with prevention. Sometimes medications, sometimes just lifestyle change, again, looking at what we can do that would optimize your bone health that way. And then osteoporosis would be a score of minus 2.5 or lower. So, and that, of course, is telling us that you're definitely at risk for fracture.
Your bones should be stronger, and they're not. They're
Correct.
weaker, and that is what that number means.
Yes.
In comparison to that 20-year-old standard, your bones look different.
Right.
And so, too, it's almost kind of like a little bit of a wave. It's like, hey, are we there? Okay, we're somewhere. Now we're really there.
Right.
So nothing to osteopenia to osteoporosis.
Correct.
So, too, our patient population, we're primarily hormone replacement clinics. So we're seeing a lot of menopausal, perimenopausal, postmenopausal, and suboptimal testosterone or clinical hypogonad. Are those the typical patients? Is it the low hormone patients? Is there any other patients that are like, hey, these could be osteoporosis?
Yes, definitely. There's other patients. I mean, we talk about obesity a lot, you know,
Right.
and
that's
that,
from stress? Is that just literally from load bearing?
well, no, actually, you think about with osteoporosis, you think the one thing that puts you at risk, of course, is being petite and being female and being of Caucasian race. You can't change those things really. So you think about osteoporosis a lot of times with a more petite female or a more frail body type. But with obesity and with the stress actually could make the bone stronger if you have more muscle or more weight, let's say, because we're building bone with weight-bearing exercise.
Right.
However, it affects the quality of the bone. So you think about obesity, you think about increased inflammation in your body, possibly metabolic syndrome, most likely a poor diet. So your bones aren't getting the nutrition that they need. And even though you're putting more weight through them to create a stronger bone, in theory, the quality of the bone could be affected. So it can lead to softer bones and still fractures.
So to feed the bone, so if we're talking about, you mentioned two great things in there, poor nutrition leading to weaker bones, and also to weight-bearing exercises to improve bone health.
Correct.
What are some of kind of like the standard ABCs of what do you do for prevention to strengthen your bones? Or even too, if you encourage, I'm all about start things in your late 20s, early 30s. Sure. Start now so later on we're not doing it. What are some of those things, nutrition and exercise, that we should be looking for?
Right. So, you know, the basis that we really talk about for all kind of prevention of health issues or chronic health illness would be, you know, a healthy diet. You want to have a well-balanced diet. You're having, balance with protein and veggies and keeping a healthy weight. Calcium and vitamin D, of course, are building blocks of the bone, so that's really important. We talk a lot about vitamin D and calcium.
Right. And two, we get questioned about calcium all the time. So so tell us a little bit more. Vitamin D, yes, vitamin D is for everything. If you choose one thing to do, choose vitamin D. That is the easiest thing. And two, it's beneficial. And it's beneficial like system-wide, but especially for bones too, it's beneficial.
Because vitamin D, of course, is helping you to absorb the calcium from the foods that you're eating, because your body has to have calcium to function. So if you're not getting calcium in your diet or in a supplement, then your body is going to the bones to take the calcium to function, for your muscles to function. And so you have to have the vitamin D on board to absorb the calcium from your gut so that that's not happening. So we see a lot of vitamin D deficiency in patients with osteopenia and osteoporosis. So that's very important. The calcium is a good question. Dr. Rogers and I talk about this a lot, and I think we get a lot of questions about calcium for sure.
Should we take it? Should we not?
Right, because there's concern about calcification in the
Right.
heart, calcifications in the joints. I think the number one best rule for calcium is you need to get it in your diet. I mean, I definitely agree with that. I think that's the best way to get the adequate amount of calcium. When we're talking about patients for prevention or treatment, we want to target usually around 1,000 milligrams a day. And so if you can get that in your food, then you certainly don't have to take a supplement. You may still need the vitamin D, of course,
Right.
supplement, but not a calcium supplement. However, if you're not doing that, let's say you have a poor diet, you don't eat any dairy products, you don't eat any leafy greens, then you may need a calcium supplement.
Almost like something is better than nothing.
Right.
Okay.
And so I encourage all my patients when we talk about this is keep a food diary. That's good for a lot of reasons. You don't have to do it forever, but for like 3 days, and let's look at how much calcium you're getting. And then we can determine, are you getting enough or are you not? And then we supplement when we need to.
Right.
And then of course the vitamin D for sure. And I always check everyone's vitamin D. I know we do that here. And sometimes people need higher doses than others. It just depends on where they are on the spectrum. And then too, some of the medications we use for osteoporosis, like Prolia, for example.
Yeah. Prolia I feel like that would be the one I was like, oh yeah. Osteoporosis. Is that kind of a go-to for you?
It is I do prescribe it. I have prescribed it a lot because patients tolerate it really well. It's once every 6 months, so it's easy to do. But it can lead to some hypocalcemia. So you have to make sure patients are getting enough calcium in their diet or taking a supplement if needed. So that's one that you worry about with that, specifically talking about calcium and vitamin D with medications. But yeah, it's very popular. It's very well tolerated. It works well, definitely improves the bone density. Certainly if you're a patient that's had insufficiency fractures, one or multiple, that's when we start really thinking we need to do something else.
Or when do you medically intervene? I'm all about, hey, okay, so we're doing everything we can nutritional wise. I've optimized weight. I am replacing my hormones. I am doing weight-bearing exercises, and just a tad on that.
Yes.
Builds bones back. Why weight-bearing exercises?
Yes. So weight-bearing exercise, because what you're doing is creating stress on the bone. So, lifting weights, weight training, you're putting stress on the bone, which is causing the bone to react to the stress and build it stronger. Right. So if you think about your bone is constantly kind of breaking down and remodeling on this very microscopic level all the time. And so as we get older, one of the things is that slows down. So we're losing more than we're building. But by doing weight bearing exercise, walking, even yoga, because you're weight bearing through upper and lower extremity, lightweight training, it doesn't have to be bodybuilding type stuff. Even though swimming is a great exercise, it's not obviously a weight bearing exercise.
It's low impact.
Right. Exactly. So it's good for many reasons, not that great of an osteoporosis prevention exercise. But yeah, anything that you're doing that can build muscle and put stress on the bone is going to help to build bone. And walking is the simplest thing.
And it's something. I always say with exercise, I talked about that a lot today. Make it habit. I feel like if you make exercise a habit, no matter what it is, that can turn into other things. Set aside Ben and my mom. Oh my God love them. They used to find their 20. You remember, I'm talking to the booth right now. She used to find her 20 and just move those legs.
There you go.
I'm dead. I loved it. Yeah, she's up and we're finding our 20 right now.
Yeah.
Okay, so we've done everything. We've done nutritional. We've replaced our hormones. We are taking great vitamins and supplements. We're eating well. We're exercising. I still have osteoporosis. I still have osteopenia. When do you like to intervene medically?
So I think this is very patient dependent, and like everything that we do, right? Because if you have a patient that has very little other risk factors, okay, and their T-score, let's say, is osteopenia. They're not osteoporotic yet, but they are osteopenic.
So midway. So nothing.
Yes, so they're midway, and we've done a bone density, and we've done one again in 2 years, and now their number has gotten worse. Then I would have a serious talk with them about adding some kind of medication to that, some type of prescription medication. And that again is very patient dependent, because some of them have side effects that we don't want, and other people could be at higher risk for some of those side effects. But I mean, oral bisphosphonates have a place, I think, for people.
Okay, that's like Fosamax?
Yes, like Fosamax, Actonel, Beniva, as well as injectable medications like Prolia, which we mentioned, which is an every 6-month injection. And then if we have a patient, let's say, that has done all the preventative things they know to do, but they've had worsening bone density, and now they've had, let's say, a fracture, or hopefully not, but 2 fractures. now we might need to treat that person more aggressively. And there's medications that we use that actually are daily injections that build bone as an anabolic agent, just like we think about anabolic steroids,
right,
our hormone replacement. But it's actually kind of a like a parathyroid hormone, and we're giving it to you in such a teriparatide. Yes.
Oh my God.
And there's a couple of trade name drugs for that, and then there's one that's been around for years, and then there's a generic form. But that would probably be the most aggressive treatment that we have that really can change the quality of the bone and I don't want to say it's not going to reverse your osteoporosis, but it's going to improve your bone density a significant amount. And then we still have to put you on some kind of long-term maintenance, because just like a lot of other diseases, osteoporosis is a chronic disease.
Yeah.
So, once we start treating it, we really have to continue to treat it forever, or you'll start losing bone again if we stop the treatment.
So we start early, and so much of our health comes from what we put in our mouth. We are tanks, we're engines, and if you do not change the oil, if you do not put premium gas in, your car will not run as well. It just won't. You got to get it out, and you got to make it move. So exercise, nutrition, huge. So that's something you could do early. But two, it sounds like get screenings, right?
Yes,
get your Dexa
absolutely.
Scans.
Yes, and we think about insurance will cover that. That's a preventative test that insurance will cover.
I'm thinking this isn't an MRI. This isn't a CT. This isn't a needle. It's a quick picture.
It's a simple test. And for women, a lot of times they do them at the same place where you might go get your mammogram if you do that. And so you can get it at the same time. Typically, we don't do DEXAs once a year, but you could do them. Your insurance typically will pay for you to have one every 2 years. Sometimes if you've had several that are normal, you don't have to get them that often.
Right.
Yeah, again, everything is patient dependent. We have to look at all the pieces of the puzzle. That's one piece of the puzzle, and then there's so many more as far as risk factors go.
I love this piece of the puzzle because we have not had that before at Performance Medicine, which is so nice. We've had diabetes, metabolic disorder. We've had people who are very interested in thyroid and gut, Robin with the gut. We've had a lot of different pieces. We have not had the bone piece.
Yeah.
And bone, that is building structure. That literally allows you to be a flop of muddled mess.
Yeah, that would not be good.
If you did not have bones, think what you'd be. You'd be on the floor. So you need your bones. So we got to protect our bones too. So I'm so glad that we have you here to be our bone specialist, to be our osteoporosis lead and osteopenia lead. It's just, I think that we need to take this very seriously and very importantly, because fractures can really, you can take a downward turn after a fracture.
For sure. I mean, hip fracture, really after a patient has a hip fracture, the mortality rate in the first year is almost 30%.
That cannot be understated. That is huge.
Yeah.
And that is something that we can work on to prevent.
For sure. Yes. And so again, prevention is the key.
An ounce of prevention, pound of cure. Is that right? Is that right? Or is it a pound of prevention, ounce of prevention, pound of cure? Yeah. All that stuff. I got bones on the mind.
Exactly. So. And, thinking about bones, thinking about osteoarthritis as well. I mean,
absolutely.
That's a different topic. We can talk about that later, but that's another thing that that I can certainly help people with as well.
It's all about the bones, ladies and gentlemen, here at the Bristol location. May bones be forever in your favor, right? No, that didn't work. I just made that up. But whatever. Come to Bristol. If you are someone that wants to check out what your bone health can be, which I think we all should be, and I think that's so interesting too. I've never thought about it preventatively, yes, but I'm thinking everything now, because literally I look at Dad and I'm like, that's me. That's me. What's he doing? Like, that's me in 30 years.
Right.
What do I like? Which is great. Thank God. Right. But still, I always think, what steps do I need to do now so that when I get to the age where all these things are happening, I've already had a couple decades into preventative treatment. Right. So I think it's important for all of our patient population, but especially ones that are going to be at a little bit higher risk. So I'm psyched. It's all about the bones.
All about the bones.
So come see us. Come see Jill at the Bristol location. Let's talk about bones.
Okay. Sounds good.
Thank you for another episode of Outside the Box. Please sure to tune in and subscribe.
Thank you.
Don't go away.